Hello, my name is Dr. Ann Bassett, and I'm the Douglas Chair in 22q11.2 deletion syndrome at the University of Toronto and the Toronto General Hospital and the Centre for Addiction and Mental Health in Toronto, Ontario, Canada. And I'm going to be talking to you today about optimizing outcomes for adults with 22q11.2 deletion syndrome, which I will probably abbreviate as 22q because it's a bit easier. I'd like to start first with what most families and most patients with 22q11.2 deletion syndrome face. And that's at the start, it's the diagnostic odyssey to actually getting a diagnosis for the person's condition. This is very often quite delayed. For our adults with 22q, it's delayed several years on average, and we found working with Donna McDonald-McGinn and colleagues at the Children's Hospital of Philadelphia that even there at a major 22q center, and for children born 1998 or after, the average delay was 1.6 years. But for our adults, it was much longer on average. A shorter diagnostic delay if the major features, congenital heart defects or velopharyngeal insufficiency, so the major palatal defects, so the major congenital features were present or European ancestry. So on average, we found that our adults had been seen by 7 different clinical specialty areas with a range from 2 to 15 before the diagnosis. And the diagnostic delay was prolonged, especially, as I just mentioned, if there were no typical physical congenital features, which there aren't in a number of patients, or the individual was of non-European ancestry. And this is even at 2 major 22q centers, Philadelphia and Toronto, and even for individuals born in the molecular testing era, so that's after 1994, only a minority were diagnosed before age 1. So we still need a lot of education to improve clinical recognition and testing amongst doctors and other healthcare providers. And we're, as a group, internationally very interested, and certainly at the Foundation, very interested in developing newborn screening methods that could be rolled out that would maximize earlier detection and provide the best opportunity to optimize outcomes. And you'll see that that's a theme throughout this. The earlier we find an associated condition, the better it is for the person with 22q, because then we can provide optimal treatment. So who are we? I'm part of a wonderful group of professionals, social worker, dietitian, doctors, and a fabulous coordinator at our clinic for adults with 22q, the Dalglish Family 22q Clinic at the Toronto General Hospital, although we've been following patients, adults with 22q since about 1992 at another Toronto hospital. So we have seen hundreds of individuals age 17 and older, and we provide clinical care and research without which we wouldn't know how to do the clinical care the best, providing comprehensive assessment, family involvement, long-term follow-up, and care for predominantly only Canadian patients because of our healthcare system. So what about expression in 22q? Well, there's a high degree of variability between individuals, and that's normal for this and most other genetic conditions. So the health issues change over time. For babies, for infants, it's all about the birth defects, the feeding difficulties, the developmental delays, and then for children, very much the focus is on speech delay, palatal problems, getting nose seen to and fixed, still, of course, the developmental delays, and then the onset, possibly, of some attentional, emotional, and behavioral problems, and treatable medical issues that need attention, of course. In adults, the focus is much more on functioning, what are they going to do, how are they going to be, where are they going to live, and optimizing functioning for our patients. The learning difficulties remain an issue throughout life, And coming to the fore are treatable psychiatric illnesses and always treatable medical problems, not only those that are chronic from childhood, but also new onset medical problems that we're going to talk about. So what are the 7 most common lifetime features in adults with 22q? Well, the intellectual disability, huge range of abilities and disabilities in 22q. Most individuals, however, do have learning difficulties. So this is by far the vast majority, but a huge range within the condition. Low calcium levels, very common. Psychiatric illness, very common, even when we account for, people not coming to us through a psychiatric clinic, but coming for cardiac care. It's still very high treatable psychiatric illness. Scoliosis or curvatures of the spine are common. Palatal insufficiency, like velopharyngeal insufficiency, very common. Recurrent seizures are also common in 22q, and recurrent pneumonia is mostly in children, usually resolving by adulthood. Other lifetime features that we see pretty commonly: obesity, thyroid conditions occur in about 1 in 4 individuals with 22q, again across the lifespan, usually earlier onset age than in the general population. Gallstones are pretty common. Low platelet counts inherently in the condition are quite common, not usually to the point of needing treatment, but they're pretty common. They're there and people notice them. Congenital heart defects, if you look within individuals who were found first because they had a psychiatric illness, then about 1 in 4 individuals has a congenital heart defect. If, on the other hand, you're finding most of your patients through cardiac clinics, and of course nearly 100% or a huge majority will have congenital heart defects requiring surgery. So the proportion is is actually variable across the condition depending on where patients come to attention. Asthma is pretty common. Hearing deficits are also pretty common in 22q. But there's a very, very high degree of variability of the burden of illness in 22q, both with respect to the severity of each individual condition, but also with respect to the number of medically actionable features of 22q that the person has. And this graph shows at an average age of only 30 years old, the big variety of the number of features of 22q that an individual has. So you see the range is from 1 to 23 features by an average age of 30, but with a differing degree of severity. But the median is 9. This is a big burden of illness for many individuals with this condition, but it varies. Some lighter, some heavier with respect to the burden. Not surprisingly, this burden of illness does affect long-term survival. So we've recently published on our first 309 adults with 22q, and I'm presenting here the survival expectations within our cohort of individuals, of adults with 22q. So survival to age 40 is over 95%. It's even over 80% with a major congenital heart defect like tetralogy of Fallot. Survival to age 50 years is also absolutely what we expect for the majority of people with 22q. It's 84% are expected to survive to age 50, and over 60% even of those with a major heart defect like tetralogy of Fallot or something like a blue baby type congenital heart defect, over 60% will be expected to survive to age 50. No difference between males and females, no difference for those with or without a major psychiatric illness, and as expected, survival is affected by the presence of a major congenital heart disease like tetralogy of Fallot, and you can see that from the numbers here. So the median age at death in our individuals, we've had 31 patients die, all of whom are still helping us actually in our research. They're the true angels for our research studies. The median age at death was 51 years of age for those with no major heart defect, but a huge age range from 18 to 68. That's for those with no major heart defect. and the median age at death so far in our patients has been 37 years for those with major congenital heart defects. So half die before age 37, half die after age 37. You can see here the range, again, is from 18 into the 60s, even for those with a major heart defect like tetralogy of Fallot. And I'll also say here that since we last did this study of survival and mortality in 22q 10 years ago, the age at death, the average age at death, has increased by 5 years. So we're certainly moving in the right direction for our adults with 22q and the care that they're being provided. So as I mentioned, low calcium levels are very common in 22q. About 80% of our adult patients had a lifetime history of hypocalcemia. Rarely that's for babies in the first few weeks of life, but most of them develop hypocalcemia over life. And overall, what you can see here is that the trend is that instead of being in this box E, which is where the general population is, there's a shift lower for lower levels, also with relatively lower levels of parathyroid hormone. So that's called relative hypoparathyroidism. That's the hormone that controls calcium levels in the body. So the treatable factors that are associated with low calcium include having a low thyroid functioning. That's easily treatable with thyroid supplements, and low magnesium levels, also easily treated with magnesium supplements. But of course, you need to be tested for these two conditions at the same time that you test using ionized calcium. This is in the clinical practice guidelines for 22q. So what can we do about this? Well, prevention and management. So the guidelines recommend for every adult with 22q 2,000 international units of vitamin D daily, and dietary measures including sometimes calcium supplements or just higher levels of calcium in the diet. But the extra of the vitamin D seems to be really important. We recommend monitoring with these simple blood tests that I already mentioned, and of course being alert for fatigue or tiredness, which is one of the symptoms that can happen with people who have low calcium levels. The most common, though, is there are no symptoms, or the patient doesn't complain at all. But they can have fatigue for lots of reasons, but including for low calcium, and they can have irritability of their nervous system. And what does that mean? It can look like tremors, so shakiness. It can look like tics or twitches or other movements that are not controllable really by the person. And the reason that we want to prevent and manage low calcium is because it can lead to seizures. So this is a treatable, manageable, preventable cause of seizures, which we would really like to be able to do for all of our patients with 22q. So we want to treat the associated conditions, as I mentioned, thyroid medications if the person has low thyroid, magnesium supplements if they have low magnesium, and for everybody treating the likelihood of the low calcium with the vitamin D. What does vitamin D do? It helps absorb the calcium. So that's the most important thing to provide for patients with 22q. With respect to low calcium. So we have found in our adults, quite different from what's in the pediatric population age range, is that compared to adult population norms, that pretty early on in adulthood, you see an increased prevalence of individuals who develop obesity. So at age 18, 19, they're higher, but not significantly higher than the general population. But by the pretty young age of 20 to 34, either with or without medications that can increase the risk of obesity, people in general with 22q, adults, have a higher, much higher prevalence of obesity than the general population does. This is extremely variable. So what you have is a sort of a general trend over the adult age range of an increase in the basal mass index, so the BMI, that it should be measured for all patients. So gradual increase in the prevalence of obesity. But some people, even at very young ages, have very high, so these are extremely high levels of obesity. So this is also a treatable condition. So, but the prevalence is definitely higher, and along with that, probably, goes an increased risk of type 2 diabetes. So we had 4.8% of our patients develop type 2 diabetes at an average age of 39.5 years, so a lot younger than in the general population. We need to get more research into that area. So what do we do? Prevention and management again. So standard measures, as in the general population, activities and exercise and dietary measures, just as it is for anybody else with obesity issues, and starting early. So this is something that we're recommending at transition when patients come across from our wonderful pediatric hospital, the Hospital for Sick Children. We're starting with recommendations to pay attention to this risk. So what about brain-related expression? Again, a high degree of variability is normal for patients with 22q. So what does this look like over the lifespan? Well, I mean, you could go right back to babies. They have a risk for neonatal seizures, usually related to low calcium, so entirely treatable and manageable. Developmental delay and intellectual disabilities, so of course, very much a part of 22q. Some patients have autism spectrum features and or disorder. Many patients have, as children, attention deficit disorder. Then the conditions that are of increased concern to us in the adult world are recurrent seizures, sometimes epilepsy, mood and anxiety disorders, all treatable, schizophrenia and other psychotic disorders, also all treatable, and neurodegenerative disorders, in particular early onset Parkinson's disease, by about, on average, age about 40, also entirely treatable, all now known to be associated with 22q and all manageable. So what about the intellectual levels? Big range for individuals with 22q. Very few individuals are in the severe to moderate intellectual range, although this is probably due to under-recognition in this patient population with more severe levels of intellectual disability. Most patients fall in the mild to borderline range of intellectual abilities, and then also another minority are in the average range, and this is a minority that may be increasing, but still is observable in the adult patient population. Even with average intellect, though, so this is across the intellectual range here, there's a neurocognitive profile on average that we can observe in adults with 22q. So if they don't have the same blanket overall intellectual disability across the board in different areas, no, there are, on average, relative strengths and relative weaknesses in this condition. So the relative strengths are in the area of recognition memory. So this indicates that people with 22q are really good. In fact, if you don't have a psychotic illness like schizophrenia, you can actually be even better than a little bit better than the average general population expectation if you're given a prompt. So what kind of prompt do you give to help people with their recognition memory? Well, it's a hint. It's a helpful hint. And you probably have seen this yourself or in individuals with your loved ones with 22q. They're also often a little bit better maybe with visual cues than with just auditory being reminded. It's like it's in one ear and out the other. So visual memory often you can use that where there may be a relative strength. So texting someone, getting a picture, and using that as a prompt to help with reminders for the short-term memory problems that are very, very common in 22q. Another area of particular weakness for many patients is in motor realm. Sometimes that's fine motor, although we've certainly had patients who can, do beautiful work with their hands. It just depends again on the individual. But on average, there are motor problems that are pretty pervasive in this condition. And then again, on average, people tend to be impaired on executive neurocognitive tasks, and these tend to predict overall functioning. So this would be things like abstract reasoning, judgment, that sort of thing, where there certainly can be deficits in 22q. So what do you do? So first and foremost, the individual is the most important in this equation. You want to, as for anyone, play to their strengths, and you want to support their relative weaknesses. For anyone with 22q, this is going to include paying attention to routine and structure. Having things organized and in a routine manner is really, really, really helpful for the person with 22q. The other thing that's particularly helpful is having realistic expectations for that person, which is why having the neurocognitive profile is so helpful for our patients with 22q. And then providing support and encouragement along with those realistic expectations. If the family or the environment or the workplace or the school where the person is, a lot of the time, has very high or unrealistically high expectations for the person that are way over and above what they can actually do. And this can happen very often for individuals who are pretty good verbally and can talk well, and look good, and so they seem like they should be able to do all sorts of things, but they actually have particular deficits, perhaps in certain areas, in short-term memory, in money management, in arithmetic, in judgment. That gap between the expectations that are based on how the person looks and seems and sounds at first glance and what they actually can have the capability to do causes huge frustrations both for the person and for the family and in the environment. So having those realistic expectations that are well matched to the actual abilities of the person, that's very, very important, can really help reduce frustrations for everybody. So how can you help? Well, you can carry and use a calculator. Well, what's that now? It's a cell phone for everybody for the arithmetic problems. Be aware of the impact of fatigue, very prominent often in many individuals with 22q, and provide lots of reminders, repeated reminders, particularly those that are written or in some way visual. And if the person with 22q can help figure out what the best reminders are, that's the best by far the way to go. And then for the caregivers, it's you trust the person with 22q, but you want to verify that they keep on track. So you keep checking that things are working. The person they may think that they're taking all of their medications, and they may want to be taking, for example, all their medications, but that is something that often needs to be actually verified, because they may be putting a bit of a rosy glow on things that may not be entirely accurate. And we also have written about huge internet safety issues in 22q. These are part of issues with being able to judge social situations, judge people, and the fact that many of our individuals with 22q tend to be taken advantage of by others. And this is something else that really needs to be guarded against. And there are some profound safety issues have arisen for our patients, particularly through the internet. So what about epilepsy and seizures in 22q? Well, there is certainly an increased lifetime prevalence in 22q compared to the general population. For these treatable conditions, the age at onset is variable, right from the newborn period to any age through adulthood. All forms of seizures are possible: generalized or grand mal seizures, focal seizures, myoclonic seizures that can look like sort of twitches or clumsiness, people kind of tripping or dropping things, and absence seizures, which can just look like blankness. They can be single or they can be recurrent, that is, keep happening. They can be what's called unprovoked, that is, seem to come out of nowhere, or they can be related to identifiable factors like low calcium levels, low magnesium levels, or sometimes medication side effects. But the underlying tendency in 22q is to have a lowered seizure threshold, so it's easier to have a seizure if you have 22q, with or without a medication, with or without low calcium, with or without low magnesium. But these are things that you can maybe actually do something about. Rarely seizures are secondary to malformations of brain development, and these would usually have been found at diagnosis or when the person has an MRI scan. For all seizures, it's standard management, including anti-seizure medications. And again, the neurologists would know best about this, and if you see an epilepsy specialist, probably best of all for patients with 22q, and have the right investigations and then management. Movement disorders are also quite common in 22q, but you have to be very careful about what other conditions, additional conditions called comorbid here, that may be present that you need to consider when somebody seems to have a movement disorder like a dystonia or tremor or something like that. And you want to, again, go to a movement disorder specialist, a neurologist who specializes in movement disorders, along with making sure they have the clinical practice guidelines and probably these papers on movement disorders in 22q, so that you can make sure that the other conditions are taken into account and managed appropriately. We have this little sign here with a big X through the Coca-Cola. It could be Pepsi. We should probably do equal opportunity and have any cola drink down here. Why is that? That's because caffeine, particularly in pop drinks or energy drinks or any of those things, can really increase agitation and movement disorders in our patients with 22q. And we have a picture of vitamin D here because that's very important for the low calcium that's associated with 22q, that can be associated with movement disorders. So what about treatable psychiatric illness in adults with 22q? This is a major concern for many families of individuals with 22q, particularly with respect to the 20 to 25-fold increased risk for schizophrenia over general population expectations. But actually, I want to point out that the most common treatable psychiatric illness associated with 22q is generalized anxiety disorder, where it's about twice the expected rate in the general population, and is very common. So what are called non-psychotic disorders, so not schizophrenia, but other things like depression, anxiety, and attention deficit disorder are actually more common than schizophrenia is in 22q. All of these conditions are however, treatable. So what do you have to do first? You have to get an accurate diagnosis of a treatable psychiatric condition. So what does that mean? The doctor has to look for the history of signs and symptoms over time, and you're best placed to help the doctor with that, in addition to the patient with 22q. Their past psychiatric history, their medical history, extremely important, their family history, baseline and best functioning, very, very important. If the psychiatric illness does not affect functioning, it's not a psychiatric illness that needs treatment. But most psychiatric illnesses, that certainly the ones that require treatment, will affect the functioning, the social functioning, the occupational functioning, the school functioning of the individual, and even self-care is affected with psychiatric illness. The social history, very important. The examination by the doctor, which will include a mental status examination, and then any history of treatment response and side effects for treatments that have been used previously. So what can we do about this increased risk of developing a psychiatric illness in 22q? Well, over the lifespan, that's a bit motherhood and apple pie, but still, it's very true that good nutrition and physical activity will be helpful for anyone who's at risk for a psychiatric illness. Avoiding alcohol and street drugs, including marijuana, which has been shown to be a very important factor for increasing risk of major psychiatric illness. Very important to avoid. Sometimes hard to avoid, but very important. If you can avoid it or minimize it, that's by far the best approach from a preventive healthcare perspective. Genetic counseling, that is understanding that there's a risk for these conditions. So being forewarned is forearmed. You're not overly anxious about this possibility, but you know to go for early diagnosis and effective treatment if you see changes in your loved one with 22q. And then it's getting that early diagnosis and getting that effective treatment available for the person with 22q and optimizing that psychiatric care and treating these treatable conditions. So what about the schizophrenia risk? This is something that many people are very concerned about and is certainly prevalent even in the general population. It affects about 1 in 100 people, and about 3 in every 100 people will have a psychotic illness. What does psychotic mean? Psychosis means being out of touch with reality. It's not criminality, and it's not split personality. That's in Hollywood. It's a disease that usually strikes the young, and it does so in 22q as well. Onset is most commonly from teens to 20s, but it will occur very occasionally in children, and it certainly will occur after the age of the mid-20s in a minority of individuals in the general population and in 22q. The signs and symptoms of the illness, the psychosis part, the out of touch with reality part, usually involves changes in thinking. Hallucinations are things like hearing voices, seeing visions. Delusions are fixed false beliefs, things that aren't true, often in the form of paranoid delusions, so overly suspicious of other people's motives, believing that people are talking about them behind your back, laughing about them, that sort of thing. Changes in behavior. Misinterpretations, that's the other way to think about the thinking changes. Changes in behavior like social withdrawal, even from the family into the room, not coming out and having meals with the family, for example. Being grossly disorganized in behavior. This can include harming oneself or temper explosions, doing things that are completely out of character for that person. Emotional changes. Schizophrenia is often a very depressing illness. People are very often also anxious when they have these changes in their thinking. They're very often really irritable and can have what's called blunting of emotional expression, so not showing facial expression, which can be an issue in 22q just as a baseline. All of these things, though, are changes in the person. If they were always one way, and it's not affecting their functioning, it's not something worth thinking about very much. But if the person used to be one way and now they're a different way, so you observe a change, that's when to go and seek help. The course of illness is usually lifelong, and it is serious. It affects functioning, work and school, and in relationships for many people. It is, however, treatable. The mainstay of treatment are antipsychotic medications. These are as effective in individuals with 22q as they are in the general population, it seems, with some caveats that you have to take care of all the other medical problems as well, and absolutely support and rehabilitation and education about this illness and what it means and what it doesn't mean. There are no lab or imaging or other diagnostic tests for schizophrenia. It's a clinical diagnosis involving understanding and appreciating the signs and symptoms over time, and this is where the family is so important to help with that, to help the specialist with that. So what do? What's standard management for each individual condition? For psychiatric conditions, just as it is for the medical conditions. You're not using a different medication for the thyroid illness. You're not doing a different surgical approach basically for 22q as you are for anybody else with tetralogy of Fallot, for example. You're using standard management, and so it is with psychiatric illness. You have to pay very close attention, however, to the investigations and the monitoring and the anticipatory care that are recommended in the clinical practice guidelines for 22q. You have to pay extra attention to the medication side effects and the interactions. That's the doctor's job to do that. And the goal overall for everybody is to maximize the individual's functioning. That's the most important thing. You can still have some symptoms if you're back functioning. That's the main thing. And you have a good, reasonable quality of life. For all individuals, I think it's very important to involve the family and the caregiver because they are the best place usually to help monitor for the changes in thinking, emotions, behavior, the sleep changes, the changes in the body, appetite, weight, that sort of thing. The parent caregiver usually knows best. And you're going to seek help if there are concerns and help the patient with 22q do that. So what can what are some things to consider that you can manage in addition to the mainstay of treatment? So for anxiety disorders, it's anti-anxiety medications and cognitive behavioral therapy, for example. For psychotic illnesses like schizophrenia, it's antipsychotic medications. But you also, for all individuals with 22q, have to be on top of and manage the calcium levels, the thyroid hormone levels, low oxygen potential for some conditions like sleep apnea and asthma can certainly worsen brain functioning and heart functioning if those are not treated with, for example, CPAP or BiPAP, or for the puffers for asthma. You have to pay attention to hearing impairment. You don't want to be, having the person being misinterpreting what they're hearing because their ears are plugged up with earwax, and what you need is syringing or earwax removal. Constipation, if it's severe, that can cause anxiety. So again, you don't want to be treating for an anxiety disorder when what you have is constipation. You really need to manage that very well. And of course, physical and other emotional stresses you need to be aware of. The caffeine I already mentioned and other substances absolutely are a major consideration and can worsen agitation. And we have seen, without question, that worsen anxiety and even psychosis in individuals with 22q, and of course the seizure risk and signs of that. So what else are we considering? We're considering the emotional outbursts that are pretty common in individuals with 22q. They're way more common, however, with untreated or undertreated major psychiatric illnesses like anxiety disorders and schizophrenia. So once you get those under control, these emotional storms where the person out of the blue seemingly blows up and screams and shouts and throws things and swears and totally out of character, and then whoom, it's over, those sort of things, those are way better when the psychiatric illness is treated and all of the other medical conditions are taken care of. We need to consider for sure the learning disabilities and overload-related frustrations. Again, matching the expectations of the individual's endowment and the environment to the individual. So you have to match the expectations that people have. If there's a mismatch, that is really going to increase anxiety and agitation in the person. Routine and structure, again, are your best friends for everybody with 22q. Treat the treatable psychiatric disorders and pay attention to the alcohol and drug use, which can really creep up on you and very much worsens the irritability and the risk for the mood, anxiety, and psychotic illnesses. So the mainstay, and something that you'll want to read and you'll want all of your doctors and other healthcare providers to have on hand, are the practical guidelines that our international consortium has developed over the years for patients with 22q. The first ones, they're published in a pediatric journal, but they're really useful for adults. They've got great tables, really helpful things for everybody from surgeons and anesthetists right through all the medical subspecialties and your family doctor and the psychiatrist. It's all in there. And then specific guidelines also for managing adults with 22q. So all the anticipatory care things are in here in the recommendations and in both of them. These are available on the website of the foundation, and they're all freely available to anyone internationally. So what about vocational functioning? What about outcomes in 22q? Well, again, there's a huge amount of individual variability in functioning in 22q. Definitely, it's affected by intellectual endowment and by the schizophrenia, but nevertheless, as indicated by this little star here, we have individuals, yes, without the schizophrenia, but with intellectual disability who are functioning way above where one would expect them to be functioning for their intellectual disability. So here are some of the findings that we had when we published this in 2012. For those individuals with no psychotic illness like schizophrenia, a minority were unemployed or disabled. A minority had part-time work, and about half were in full-time work or school. Those with schizophrenia, the percentages were somewhat different, associated with the illness, and that's the same as in the general population. So many patients with 22q are fantastic at work. Really, employers would dream of having such wonderful people working for them, but it has to be a good match. The person cannot be exploited at work in any way, and so careful monitoring and matching for the person's abilities is really important. Adults with 22q are a growing population. Better pediatric care, better care overall. Individuals with 22q most don't have any problem with fertility. More babies with 22q are being born. So it's a growing population. We want standard management for each individual condition. The investigations, monitoring, anticipatory care that's recommended in the guidelines, with the extra attention to medication side effects and interactions. And our overall goal is maximizing the functioning with the family and caregiver involved for almost all patients, or as possible. Genetic counseling is important, repeated over time. Why is that? That's because A, people forget, and B, there's new information all the time. So what is genetic counseling about? It's not only about the reproductive genetic counseling for those who are in the reproductive age range. For men, that's any time. For women, it's while they're still having their periods and while they're reproducing. So the risk that's 50% of transmitting the deletion needs to be understood by everybody, and the variability of that. And for everybody, regardless of whether you're reproducing or you're not, it's understanding what we know about the psychiatric and medical conditions that are associated and how these can be prevented and treated lifelong. Again, this needs to be repeated over time. And when you're talking about reproduction, you're also importantly talking about partner choices and availability of partners for people with 22q, and all the availability of contraception that would be provided for anybody in the general population. So what about fetuses who have 22q? So the illness starts before conception. So right from the embryo, there can be changes that can be apparent. And one of the things that we found is that babies who are going to be born with 22q have an increased likelihood by about 2 times that they might be premature, and they also have a 6 to 8-fold increased risk of being tiny babies, so small for gestational age. So these are higher risk pregnancies, and they should be treated as such when you know that the pregnancy is a baby with 22q. So what are the benefits of having this molecular genetic diagnosis of 22q? Well, we start with the anticipatory care and the vitamin D and the calcium supplementation, so very basic. There's safety issues, access to specialized clinics, better medical care, the social aspects, a sense of belonging to a group like the 22q Foundation, and increased opportunities to optimize your social and educational needs. Better interaction with healthcare professionals can arise from knowing what this condition is, and more that can include more respect and attention. And then we also want this to be a platform for advocacy, for greater understanding and hope for others with a sense of purpose, and certainly less blaming. Should be no blaming of parents, that's for sure, or anything to do with pregnancy or anything like that. and certainly no blaming of the individual with the condition as we understand more and more about it. So what have we got underway? Well, we have an international consortium of clinicians and researchers who are completely devoted to people with 22q, from babies and prenatal right through to the elderly with 22q. Some of the things that we're doing are searching for the changes that actually contribute to major health conditions associated with 22q, like the schizophrenia, like the congenital heart disease and outcomes. We have the promise of prospective, so that's going forward studies and treatment trials. There are lots of researchers who are involved in studying animal and cellular models of 22q to help us understand the disease mechanisms and help develop new treatments for the associated conditions. We always need further understanding of natural history of the condition and long-term outcome and management, and the overall epidemiology or the whole population field of understanding 22q, and we're very, very interested at the 22q Society in developing and implementing newborn screening so that many more families can be helped at a much earlier stage. So I'd like to acknowledge first and foremost our patients and their families, without whom we would have no knowledge about 22q. Without their involvement in research around the world, we wouldn't have advanced as we have over the past number of years. Our own clinic and research teams, many students who have helped over the years, colleagues locally here in our cardiac clinic and the Center for Applied Genomics, colleagues across Canada and internationally we work with, and many funding agencies. And I'll stop there and look forward to answering questions. Thank you.